Okay, Tara, it looks like the most of the blips to come in have stopped. So do you want me to go ahead and get started?
I think we're good to go.
Okay. So good afternoon to everyone, and thank you so much for joining our Q1 Continuous Quality Improvement Series, sponsored by Treatment Atlas and Shatterproof. We're very excited to have everyone here today, and we're really excited, and thank you all for completing the survey that had gone out about what topics you would like to see. These continuous quality improvement series are really to support you, our providers. We are so appreciative of the work that you do and partnering with us to really provide transparency within this space and to help support individuals and families that are struggling with the disease of addiction. So, one of the biggest topics that had actually come up from the survey that went out was really talking about some of the changes at the national level and federal policies. So, I'm very excited to introduce our speaker today after a few housekeeping items. So, Tara, can you move on to the agenda, please? Okay, so this is going to be the agenda for today. Please be aware that everyone will be muted. You can put questions into the chat at any point in time, and Tara and myself will be watching them and providing those to Kevin, and he will be happy to address the questions that are coming in. Next slide. Some of the Atlas updates, just wanted to let you know if all of the treatment facility surveys do need to be reattested after 24 months. You will be receiving notifications to please update and reattest your survey. This does only take about 15 minutes. So I strongly encourage everyone to reattest your survey so that your information is not lost. Last year alone, we had over 900,000 individuals come to Treatment Atlas seeking care, and we really want to make sure that everyone sees the services that you provide and are able to find you in their time of need. So please complete and update the treatment facility surveys. As I mentioned, it does only take about 15 minutes to reattest the surveys. It's not like doing the survey the first time, and you will have all of that free marketing, and the individuals that are coming to our website will be able to find you. If there are any questions at all, please reach out to atlas@shatterproof.org. Once again, that's atlas@shatterproof.org, and we will answer any questions that you have and direct you to your Director of Provider Relations. Next slide. Also wanted to make certain that everyone is aware that we do have the consumer perception of care surveys. This is anonymous, and it's open to any consumer or family member who has completed treatment. And it is available on Treatment Atlas. Once a facility has 10 or more consumer perception of care surveys, these will be posted on the platform. We know that there are more and more people that are looking at consumer perceptions of services and goods to see whether it's a good fit for them. So we strongly encourage you to have consumers complete the consumer perception of care, or have it in newsletters, alumni groups, aftercare groups, etc. And if there are any questions on the consumer perception of care survey, please let us know. We also are ever evolving, so strongly encourage everyone to check out the new user experience designs. These designs came about because through consumer testing, we found that some of the items on the platform, there were better ways and visualizations and ways to really highlight what our providers are doing and ways that it makes easy for consumers and family members to find exactly what they're looking for. So we have simplified the homepage. We've also made the facility detail pages where all of the information is about each of the facilities much clearer, in addition to having the large buttons right at the top so an individual can connect with you directly from Treatment Atlas platform. And the pictures are also very prominently displayed because we want individuals to be able to see what your facility looks like. If anyone would like to submit any additional pictures of their facility or would have any questions at all, once again, please contact atlas@shatterproof.org. Okay, and now on to our speaker for today. Our speaker is Kevin Roy. He is our Chief Public Policy Officer at Shatterproof. He leads our national advocacy initiatives, both at a federal and state level. Prior to Shatterproof, Kevin was the Executive Vice President for Autism Speaks and very engaged with public and state improvements to address gaps in research and lifespan needs. He has been led efforts to combating Autism Reauthorization Act of 2011 and the Autism Cares Act of 2014. He has successfully partnered with numerous disability organizations and continues his work today at Shatterproof. We are very appreciative of all the work that Kevin has done and his expertise within this field. And I believe that he will be able to provide a number of insights on things that are happening both at a federal and some state level and some of the areas of focus for Shatterproof for this year. Kevin?
Great. Thank you, Lisa. Just to add a little bit of that on my background, I've been now with Shatterproof for 7 years, and so really immersed in addiction-related policy through that. And our founder really started with policy as part of our own, sort of growth, if you will. In part because he recognized that we could make an impact and sort of develop a track record and expertise through policy. So my point of mentioning that is just it's been a really, critical part of what we've done, really, over the last 10 plus years, and certainly since the 7 or so years that I've been with Shatterproof. We were involved on the federal side with the MATE Act, which is legislation that required 8 hours of addiction education to be able to prescribe controlled substances. I think that's legislation that is going to have a multi-generational impact in terms of reducing stigma and really advancing the field forward, so that no matter where anyone intersects with the healthcare system, they will get an opportunity to meet with someone who's had some basic addiction education. So we're really excited about our role in that. This was signed into law back in 2022. We've also been involved in some other state policies around removing prior authorization and other restrictions to help people get treatment. So this is really a core mission priority for us, and so it's great to have a chance to chat with you. My goal for this, our time together here, is really three things: give you an overview of the addiction crisis, which I suspect a lot about, and then secondly, talk about our priorities and how they kind of are in the context of a really disruptive, unique federal environment with a lot of the system transformation and such that's underway. And then finally, I just want to take you into a little bit of a deeper dive with one of the topic areas that we're working on. So that's my goal here. And then, as Lisa said, there'll be time for questions. So this first slide here is really just a table set. Again, I suspect many of you know the significance of this cause. that there are, literally millions of people with a substance use disorder, and millions still that have been impacted by opioids. That this is one of the leading causes of death in the country, particularly when you factor in both alcohol and substance use, and that getting treatment is not easy. That not everyone is open to it at the moment maybe they need it, and also that our systems aren't necessarily paying for it in a way that's efficient to make that easier. And of course, there's a societal stigma associated with it as well, which is something certainly that we've tried to work on. And beyond the human, both life cost in terms of overdose deaths in the country, and the personal cost in terms of the challenges and the struggles people need to deal with. There's an economic cost to this that policymakers certainly, and I think we're all are interested in as well. And so there's been studies that show $1 trillion per year in potential societal impact when you factor in lost lives and productivity and the costs that go with treatment and with criminal justice involvement and the like. So again, obviously you all know this is a very timely and important issue that should be, and I think is, very high public policy priority. Next slide. In terms of the loss of life, this is, again, I suspect this, but it's worth mentioning how radically this has changed in a relatively short period of time, where you had synthetic opioids playing a fairly small part of the overall overdose picture, to the extent that it was being tested or not. So maybe it was probably a bigger part sooner than we're aware of. But you can see here from 2015, where synthetic opioids were less than 10,000 a year, to 2023, where it was more than 75,000 per year. And so, to put that number in perspective, in 2019, the total overdose death rate was at 68,000. So, I mean, more just from synthetic opioids than a few years prior from all overdoses combined. Obviously, we're happy certainly that the rate has or the number of deaths have declined year over year here over the last year and a half or so. But it's still, when I talk to policymakers, when I talk to the media about this, and they're like, hey, isn't it great? It's still catastrophically high relative even to 2019, just prior to COVID, where, as I said, it was 68, 70,000 or so, depending on the estimate range. And so to be happy that we're still 15, 20% higher than that, I think is a real really missing the lead, if you will. So obviously top priority for us, and we really try that for policymakers as well. In the next slide, this really gets to the crux of I think a lot that's going on in the world right now. Obviously, very disruptive time for I think a lot of people, with the new administration really focused on cutting costs as a means of reducing the annual federal deficit, which is $2 trillion per year, and the federal debt, which is in the trillions, and debt service, I think alone is more than $1 trillion per year. So I think we all sort of recognize that there's legitimate concerns around that, but certainly our role here and what we're trying to do is make sure that as the government is reorganizing, restructuring, there's a massive restructuring in HHS announced yesterday, literally, tens of thousands of jobs reducing, that the funding that's critical that goes to the states that actually provides treatment and services to people aren't lost. And so that's a big part of, our job, our task at hand here. And so part of what I wanted, what I did after the election was sort of try to think about the arguments and the rationale, the logic to, working with the new administration. And so we looked at some of the highlights of that are here, at least top level items. we looked at the Support Act. I was involved, I was with Shatterproof at the time, and know the administration was very involved with that. The first 1115 SUD waiver for states was granted, I think, in 2017 or 2018. So that was a administration initiative as well. And then criminal justice reform, and I'll get to this in a moment, was another area that, not in the context of treating addiction, but in the context of sentencing reform, I know was something that the administration looked at as sort of a legacy item that they were proud of. So when the election happens, you start thinking about areas of sort of opportunity. Obviously, fentanyl has been top of mind for the administration, and that's something we've had a hand in, and working. We did, I think, what was the first report on fentanyl test strips in 2018 or 2019, where we looked at state policies where paraphernalia laws were absent in the states we sampled, and made some recommendations on that. So I think we have a sort of a lot of credibility in that regard. And we've also been involved in federal oversight of mail in the context of the Support Act. There was a bill we supported in there, the STOP Act, which required the Postal Service to apply more stringent review. So this was something we'd worked on in the past, where I thought we had some credibility, and so obviously that's an area where we think there is interest, or we know there's interest. And then SUD policy in general, again, just going off sort of the campaign talk, but also the first term, very unusual in the sense, historic, in fact, only the second time where you had a non-consecutive term. So we could look back at the first term, and I mentioned the items, the ESUD waiver and the Support Act that we could look at. And also thought that, just again, conjecture on my part, but potentially prevention programming was an area that could be of interest. And so I mentioned that not because they've said so, but because there's been some interesting, I think, work done in this space on the part of the national academies and some states where maybe the policy's ripe to talk about that. And then finally, where do we sort of see our most logical opportunity? One, Atlas, and you're all obviously very well aware and invested in that. We've talked with some people in the prior administration about the potential applicability of Atlas for Medicare and Medicare Advantage. And so that's certainly something we'd like to do. And then also, very importantly, I've worked with members of Congress that have been leaders on the block grant funding over the last handful of years or so, and so we're proactively working with those offices to coordinate a letter in Congress to keep those block grant fundings at their current levels. And so those are the what are now called the Substance Use Prevention, Treatment, Recovery Services block grants, and also the state opioid response block grants, which combined have provided significant amount of resources to the state. So that's sort of immediate term. Our top priority is working with. So I expect that to be in the next couple of weeks. We'll probably be activating our grassroots to reach out to their member of Congress, because the next budget cycle is coming up, and for all the reasons I think you're probably well aware in the news, cutting budget is really the main priority right now in the immediate term, and we want to make sure that those funds in particular are not cut for the reasons I laid out at the beginning. And then also, of course, Medicaid is a critical piece of the payment infrastructure. There was Richard Frank did a piece in Brookings just in the last week or so that did as, I think, as good a job as you can do under the circumstances, given the, I think, lack of consistent data about the amount of Medicaid or amount of treatment dollars that is paid for through Medicaid, that I think is really helpful to some of our arguments about not cutting Medicaid either. What I can share, and Lisa asked me to share in terms of intel that we've heard of late. This is pretty well informed sources saying that the House leadership would love to get to their cut targets without cutting Medicaid, and they've got a sort of a back of the envelope roadmap for doing so that is made up through Medicaid work requirements, which I think a lot of states have or have explored. I think sort of a policy that's been out there and sort of well understood, and I think also well socialized in the context of Medicaid expansion. That was sort of the purpose of the policy, was to be for people where they're working. So that's one area, and then secondly, states have, probably from the federal government's point of view, have oversubscribed the use of provider taxes as a way to pay for their state share versus paying for their state share from general revenue funds. And so that's another area that they're looking at. And then I think they've also identified several $100 billion or a couple of $100 billion in energy revenue of some kind. So I share that not to try to paint a rosy picture by any stretch, but just to share some information that I'm aware of that is at least a little bit of a potential pathway to to not having some of the cuts I think people feared when they first saw the House budget. And so that's the latest I know there. This last bullet is really just to emphasize what I think everyone realizes, and I don't think anyone disputes, even those most strongly pushing for the disruption, is this is a very disruptive period in the immediate term, and we're certainly aware of that. I think that the agencies we work with, both the federal and state government, are all aware of that. We're all kind of feeling the real world impact of that, and so just got to be honest with ourselves, if no one else, about that. And so, again, back to my main point was I try to be optimistic because my experience has taught me that this is an issue that's really, really nonpartisan and over multiple administrations, including the first administration for President Trump, has shown to be pretty consistently supported. So. But anyway, in the near term, we expect kind of continued disruption, and well, I can't pretend to know more than that. So so pivoting kind of to our priorities, just to give you some insight into that. We have two programs, one of which you're very, very well familiar with, Atlas, and then we also have a stigma reduction program that is in a number of states, and we continue to talk with states all the time, every day, about those programs. I mentioned earlier that we were also had conversations with CMS about Atlas during the Biden administration. We're hopeful to renew those conversations when the disruption settles a little bit. And then, of course, those programs have a number of partnerships, and I suspect some of the folks on this call are involved in multi-state organizations, and we're always looking for leverage to work with organizations, whether it's the federal government or other partners that really have that kind of scale to help impact these programs further, benefit people further, in a more efficient way. Our three policy priorities are: one, state parity policy, and there's probably a federal hook here that's I'm not going to get into, but what we've done over the last year or so is really kind of take a fresh look at parity policy and look at what I think states are trying to do and what are the tools that are lacking. And so we've developed just a policy primer to help states with this, that is sharing a lot of what's been out there already. There's been some really diligent work in the field on consistent reporting templates to show state parity policy, so that plans and the oversight, for that matter, can have really a consistent way to look at how parity compliance is unfolded. Certainly, we're very interested and open to finding ways that Atlas can help states do that. We haven't quite been able to thread that needle yet with any state in particular, but we've had some, I think, really informed and substantive conversations. So state parity, and particularly the transparent reporting, is the near-term deliverable there, and so that's a really interesting area for us. I mentioned treatment for the criminal justice population. The Medicaid waivers that were approved, which enable state medicine, so literally a waiving of federal law, which prohibits use of Medicaid dollars to treat the incarcerated, was approved by Medicaid during the Biden administration, and a number of states applied for this, both red and blue states, so that they could start treatment as part of a transition process for those who are leaving jail. So it's 90 days prior to release, and medications for way oversimplifying this for 30 days post-release. But that's a waiver policy. We are talking with states that might not otherwise do that without us really trying to work with them and encourage them to do so. But that's happening in a number of places. We like that policy because I think it's a way to hopefully help reduce stigma, but also that the treatment pre-release has the potential to really help people have a more successful release in all the ways that are meaningful, and not just recovery from addiction, but actually in terms of avoiding crime and such. And so that's part of our rationale with some of the states that are maybe less likely to do this, is that there's some interesting data that shows it can actually help with recidivism, and that we think that's an appealing argument depending on the state. And obviously, we're well aware that this is a population at very high risk of overdose as well, and so that's an important part of it. And then finally, and this is going to be my deep dive, is the marijuana policy. So I'll just kind of at a high level, we're focused on the youth mental health linkage, and so as this issue has really grown in terms of the number of states that are allowing for recreational use. Our role has been to try to identify policies that will reduce the likelihood that youth will use it. And there's a significant association been shown in research funded by the NIH with mental health issues, particularly in an age-dependent way. So youth as well as those in kind of their early 20s. So that's another area. So moving on to the next slide. That was a segue to my deep dive, and again, we're going to leave time to address questions here at the end. This is a trend, with now 24 states or so allowing for non-medical use, and so interestingly, there's a little question of chicken or egg, whether the trend is a reflection of a trend or those states that were most open to it, or states where use is wider. And that's kind of a question I talked to a very prominent researcher about just the other day. That's still an open question. The point is, this is really over the last decade or so become much more common in a number of different states. And so we're encouraging states to adopt evidence-based protections to reduce the risk of harm to youth. Next slide. So, the reason for this is, one, as the policies have changed, the perception of risk has changed. And so one study showed those that, adolescents who believe that the risk dropped almost in half, from 47% in 2010 to 27.4% in 2019. And that adolescents in legal states had a higher past use rate, at least in one state, compared to those in non-legal states. Now, interestingly, and I referenced this a moment ago, there was another state, so that was Oregon, and another state, Colorado, that showed roughly the same use after legalization. And so there is, I think, still an unknown, sort of cause effect. However, the perception of risk does seem to show, does seem to drop with legalization, and the perception of risk does seem to be an impact in terms of use. And then another interesting study, for those who are interested, there was a study of twins that looked at legal versus non-legal, and showed a correlation with higher use in legal states. And so that was really interesting. And twin studies are always kind of interesting in that way. Next slide. And the reason we're focused on this is one, where everyone stands on legalization or not. There is a a growing and compelling body of evidence that suggests that there's an age-dependent risk of using. And so a study that came out just a few weeks ago in Canada showed an 11-fold increase of psychotic disorders in that age group, that 12 to 19 age group. And when the study looked at just emergency room and hospitalizations that could be attributed to marijuana use, it was actually much higher still, 26 times higher. So that was one recent study. The studies at the bottom of the slide go back to were publicized in 2023, the summer of 2023. The NIH did a big press release about the study they funded in Denmark. So, population-wide survey, longitudinal study showed that in the 21 to 30 age group, 30% of their cases of schizophrenia were attributed to cannabis use disorder and could therefore presumably have been prevented. And then at the same time, they released the study on casual use, which showed a 2 to 4 times higher risk of psychosocial problems for adolescents with even casual use. So again, the Denmark study showed significant risk, and then with cannabis use disorder, and then casual use was also associated with a risk. And then depending on the study, certainly have seen, or depending on the age group, I should say, some risk of suicide increase as well. And I cite here the study that showed youth males. Interestingly, the same study showed a higher risk for females at a different age cohort. So you're seeing, just some variability in terms of age dependency based on sex as well. Next slide. And so again, just kind of to give you a window into our policy work here. So what we, to address all of that, we've tried to look at the evidence base of what worked in tobacco and tobacco and alcohol prevention. And so we didn't do the research ourselves. The Partnership to End Addiction did a really terrific service to the field with a report that they released in 2023 as well, that looked at the 19 states that were legal at the time and applied the evidence base from alcohol and tobacco prevention to whether states had applied those same restrictions for marijuana use. And so again, really terrific report, which certainly we'll share the link to, and we owe them sort of a lot of credit for what they've done. And so examples, these are just very quick, high level. It's a 100+ page report, but things like product composition. So what is the potency of the actual product itself? A number of states have decided to cap the THC content, and we can get into this maybe in the question and answer, but this is getting very complicated because of the Delta 8 loophole, which is allowed for products outside of the legalized regime to be sold in the marketplace in a number of states. So, but with that said, this is still a really important tool for limiting the harm. Packaging and labeling, pretty straightforward. You see this in alcohol and tobacco. You want to have real warnings so that not just kids, but even teens, the way that labeling in fact the way that labeling impact people using cigarettes, showing the risks is the kind of labeling that can be helpful here as well. Advertising and marketing, the best practices in should require health warnings and banning depictions of particularly youth using and those sort of things, and advertisements in public places and where kids and families are expected to congregate. Next slide. Also, there's a number of zoning laws that can be helpful. Some states have had options to ban it. In counties that said they've sort of left local restrictions. Again, the proximity of retail distribution, facilities relative to where schools might be and the like. These are real opportunities to potentially limit youth use. And where I live in Maryland, where one of the states to recently pass it, you see these dispensaries in places where there used to be a fast food place, and literally people are driving up and drive through to get the product. And so these are the kind of things that, unfortunately, sort of normalize the use in a way that that may influence kids to try it. Restrictions on public use. There's secondhand smoke laws. We're working with one state where we're trying to encourage them to enforce the secondhand smoke laws with regard to to cannabis use. I think a lot of people we hear, anecdotally at least, don't like the smell of it and things they see in public, and so that's one way that states could address that. And then obviously, really important as we've seen in alcohol and tobacco, strict age verification as a way to stop kids from buying it in places. And that's where the Delta 8 problem has become really problematic, because it's not regulated at all. So that's been a real problem. Next slide. So just in sum, again, as a effort to give you some insight into our work, we're active in at least 6 states right now on this policy, and we really, again, not trying to pretend we can do more than we can, and also not trying to presume to tell the state that's just legalized it to do more than they've already done or do differently than they've done, but at a minimum encourage them to adopt policies that will make it less likely that youth will begin using, and this marijuana in particular, and hopefully avoid some of the the mental health issues that I described earlier that the research has shown. And so we're active right now in Arizona, and there's an advertising bill there. Just got a briefing from our lobbyists that we work with there this morning. Feel pretty good about that. It's through the House and not through the Senate yet. In Ohio, they did legalization through a ballot statute initiative, and so the legislature is trying to tighten things up there. We've been very active there. Missouri's actually in the category of the Delta 8 situation. They had a constitutional amendment that passed the recreational, so it's very difficult to amend that. However, they've got this Delta 8 product in convenience stores and gas stations being sold in a number of places, and they're trying to crack down on that. And then finally, I mentioned California, where they've had longstanding recreational use, but have recently passed legislation about use in cafes and such. And so that's an area where we're encouraging them to think about the applicability of their existing clean air laws for smoking. And so that's important policy as well. So I believe that's the end there, and I will again thank you for joining and the participation. And I know we have some questions, so I'll just stop there and let Tara guide us towards the best way to answer those.
All right, so I'm looking through the questions here. So Lisa did have a question. Lisa, we will be sharing the slides and a copy or a link to the recording today. And I think that's the only question that we have had come through here.
Okay, maybe as questions are being considered, I'll just thank you again. And I think I was really excited to Lisa and I work together. And we're excited to have partners in the Atlas space. And I just was going to add, it really important to hear from my perspective from all of you on the front lines about these issues. It's really a good way for us to really be understand what's going on. I see there is a question.
Kevin, I'm happy to take that one. With the increase of THC prevalence, has there been an increase in treatment requests for cannabis use disorder? Interestingly, we are seeing an increase of THC used as a filter. Currently, it comes in each month right around 4th for the most common filter that's utilized when seeking care. Previously, before THC was legalized both for medicinally and recreationally, it was very uncommon that individuals were actually seeking treatment primarily for marijuana use, unless it was, some kind of drug testing or causing issues at school, etc. But now we're really seeing it more as a primary filter that's being used. Anecdotally, I'm a licensed psychologist, and I was in practice prior to coming to Shatterproof. And whenever I started in the 90s, hardly anyone was being seen for marijuana use. So now that across the 14 states, it's number 4 pretty consistently is significant. I'm guessing the next question will be what generally comes in as number 1. Number 1, with almost a quarter of the filters utilized, 25 to 40%, is alcohol. So that is the number 1 chemical that individuals are seeking services for. Absolutely, Wesley. With the 3-1 residential, is now seeing more and more with THC marijuana use as that primary SUD diagnosis. Kevin, you might be able to answer this one. Do you happen to know from the states that you're speaking with, for those states that have made THC recreational use and or medical use, is Medicaid paying for THC as a primary diagnosis?
So yeah, thanks, Lisa. And I'm seeing there's some great information in the chat about that. Apparently, it varies state by state. And so, Wesley, thanks for sharing that it was funded or is funded in California, but evidently not in Wisconsin. And so that's really helpful information for me to be aware of.
Mhm.
My thought on this was, sort of like alcohol. I'm just doing the analogy. Alcohol's legal, and treatment is typically paid for, I would think, and so that shouldn't be a barrier, but perhaps it is, as I see Lisa is sharing about Wisconsin.
Great comments there. And as the rest of you are thinking of potentially some other questions, I just really want to thank Kevin for coming over and being willing to present during this continuous quality improvement, both on some of the issues that are impacting everyone from a federal level, and to talk through some of the most recent trends. And these were actually the 2 survey responses, 1 and 2 or 1 and 3, wanting to hear about some of the current trends and also wanting to hear about some of the policy that's occurring at a federal level. So we're just very lucky that Kevin was available and willing to present on both of those. So thank you, Kevin.
Yeah, my pleasure, of course. Yeah.
Any other questions coming in? I can see that Wesley is continuing to type, so we're looking forward to that comment. But any other questions from anyone?
We have one in the Q&A section from Karen. Coming down the pike, will there be a way to test the air or surface for marijuana for buildings, apartments, and homes be available for public use soon?
Kevin, that one would be for you.
Yeah, so I'm sorry, I was just trying to read it to understand it. So I guess the straight answer is I don't know, right? Like what sort of the protocols are. I think that's one of the what I can share is one of the challenges in the field right now is sorry, I froze. Lisa, do you want me to continue? Yeah.
Yeah, can you please repeat that, Kevin? Because I think you froze right as you were
Sure.
starting.
Yeah, sure. Sorry. I was just going to share that I don't know the answer to that about testing for buildings and apartments and such. However, that's exactly the type of regulatory issue we are encouraging California to think about in the context of how do you protect employees in a cafe where where cannabis use is allowed. So there's kind of a a health and safety for employees situation there, and those are the kind of things we've encouraged them to think about. How do how do you even do this? And it's a great point, but as to whether how you would do it in other contexts as well. And then final point I'll add is it's an issue that states are dealing with regard to impairment. Like how do you know whether someone's driving under the influence, and how do you how do people have worker safety in terms of use and such. So, and I've heard at least from from some states that's a real issue they're struggling with. So anyway, it's a great question, and unfortunately not a very helpful answer at this point. The questions?
I don't see any other at this time. So,
Great. Yeah, great point about contacting your state policy heads on that as well. Yep. Okay, well, thank you again, Lisa, for having me, and for all those who've joined the call for your interest. Really, just excited to have a chance to talk about these issues. So really appreciate your time.
thank you again. Take care.